Sir, 3, 2, 1, start.
Thank you. A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Man Singh Medical College, Jaipur. Today, we have a class on recurrent urinary tract infection. This would be presented by our resident, Dr. Sarvesh, and moderated by our faculty, Dr. Ajayraj Singh. So I would request Dr. Sarvesh to kindly share his presentation. Share his presentation.
Good morning, sir. Recurrent UTI infection refers to more than 2 infections in 6 months or more than 3 infections in 1 year. Recurrence can be due to reinfection or a relapse of persistent foci of infection. Most recurrent UTI are thought to represent reinfection with the same organism. Relapse is a symptomatic recurrent UTI with the same organism following adequate therapy. Reinfection is a recurrent UTI with previously isolated bacteria after treatment and with the negative intervening urine culture are caused by a second bacterial isolate. Epidemiology. In postmenopausal women, the prevalence rate of having one episode of UTI in given year varies from 8 to 10%. In reproductive age group, 6-month risk of second UTI is 26.6% and risk of third UTI is 2.7%. Behavioral risk factor of recurrence. Frequent intercourse is strongest risk factor more than 9 times, increases the risk 10 times. Spermicidal use of vaginal diaphragm, new sex partner in the past year, age of first UTI more than 15 years. Host risk factor for recurrence. Factor causing immunosuppressions like chronic renal insufficiency, diabetes mellitus, immunosuppressant medications, renal transplant, HIV, AIDS. Host risk factor for recurrence. Other risk factor, nosocomial factor are instrumentation, exposure to antibiotic resistance bacteria, indwelling urinary catheter, intermittent catheterization, nephrostomy tube, uteral stent. Other factor, mechanical and physiological factor affecting the bladder emptying, like incontinence, cystocele, post-voiding residual volume. Increased post-residual volume more than 50 ml is an independent risk factor for recurrent UTI in post-menopausal women. The risk factor related to infection for recurrence. The strongest predictor of recurrence were characteristics of infection with the presence of hematuria and urgency in first UTI. In Finnish study of women aged between 17 to 82 who had E. coli cystitis, 44% had a recurrence within 1 year. Estrogen and recurrent UTI. Estrogen loss in postmenopausal women leads to decreased glycogen, thinning of epithelium, alkalization of vagina. Vaginal pH rises after menopause and vaginal lactobacillus decreases, allowing gram-negative bacteria to grow and act as a uropathogens. All these changes, vaginal flora and predispose to UTI. What if the cause of recurrence in low count bacteria or even negative culture? Answer lies in intracellular bacteria colonies forming biofilm. Biofilm is uropathogenic E. coli, like E. coli CFT 017, UTI 89, and 536 invade the urothelial cell linings, the urinary bladder, which form the intracellular bacteria communities. This infection remains undetected in normal urine culture and cause recurrence. These culture-negative infections present as unexplained dysuria and urgency and are termed as interstitial cystitis and bladder pain. Microbiology part. E. coli is the predominant uropathogens isolate in the acute community required uncomplicated UTI. It's like more than 80%. Coagulase negative Staphylococcus up to 15%. Klebsiella pneumoniae up to 8%, Staph aureus up to 8%. Group B streptococci is 2 to 7%. Pseudomonas infection are relatively more common in patients with chronic catheterization. Proteus mirabilis is a common uropathogens in patients with indwelling catheter, spinal cord injuries, or structural abnormalities of the urinary tract. Diagnosis done by urine routine microscopy. Leukocyte stress nitrite deep stick, or when the prevalence is 2% or less. Deep stick culture technique. Urine culture sensitivity is the gold standard method to diagnose UTI. Deep stick method. Diagnosis. There is no specific guideline for or indication for imaging studies in women who have recurrent UTI. Indication for ultrasonography or CT scan include recurrent non-coital UTI, persistent hematuria associated with UTI, acute pyelonephritis, evidence of renal insufficiency. The possible biomarker of UTI. Serum biomarker. Granulocyte colony stimulating factor increases macrophage colony stimulating factor. Interleukin 5 increases. IgG, IgM, and IgA immunoglobulins increases. PSA also increases in UTI cases. Vitamin D deficiency are also seen in UTI patient. In urinary marker, NGF decreases, NGAL decreases, and interleukin 8 increases. First, serum biomarker. Serum antibodies were the first possible biomarker found in recurrent UTI. The level of serum antibody immunoglobulins IgG, IgM, IgA in the study patient were significantly higher than those in healthy controls. Serum hormone, granulocyte colony stimulating factor, and interleukin 5 at onset were significantly higher in the mice with the development of cystitis than those without reinfection. Macrophages CSF was found to be significantly elevated in the patient who subsequently developed recurrent UTI. Mean serum level of vitamin D among the premenopausal women with recurrent UTI were significantly lower than those of control. Deficiency of serum vitamin D also might be a biomarker of recurrent UTI. Urinary marker. Nerve growth factor is a small protein that induces survival and differentiation of neurons. Urinary NGF level were significantly increased in women with overactive bladder and were considered as a possible biomarker. Clinical presentation. Clinical presentation, the most common form of UTI is recurrent and persistent asymptomatic bacteria. However, it may also present acute cystitis or acute pyelonephritis after an untreated primary asymptomatic bacteria. Asymptomatic bacteria. According to recommendation development by IDSA, significant bacteria in asymptomatic women is defined as bacterial monoculture in the quantity of 10 to the power 5 colony forming unit per ml in 2 consecutive mid-stream clean catch urine specimen, or 10 to the power 2 colony forming unit per ml in urine collected from single urinary bladder catheterization. Asymptomatic. If asymptomatic bacteria is not treated, approximately 40% of infected women will develop symptomatic infection. Symptoms of acute cystitis. Dysuria, frequency, urgency, suprapubic pain in the absence of systemic illness, hematuria. Lower urinary tract symptoms with pyuria accompanied by sterile urinary culture may be a form of urethritis caused by chlamydia trachomatis. Acute pyelonephritis. Presented with clinical features of abrupt onset with fever, shaking chills, aching pain in one or both lumbar region, anorexia, nausea and vomiting, tenderness elicited at costovertebral angles. Microorganism in acute pyelonephritis. Most common organism is E. coli, 70 to 80%. Klebsiella pneumoniae is 3 to 5%. Enterobacter or Proteus 3 to 5%. Gram-positive organism including group B, Streptococcus and Staph aureus like is 10%. The diagnosis, gold standard in pyelonephritis is renal biopsy, but it is impractical to clinical practice. A combination of symptoms, full blood count, inflammatory markers, renal function test, blood culture, urine culture, and sensitivity testing are used. The medical complication, endotoxin-induced alveolar injury are manifest in up to 10% of women and may result in frank pulmonary edema. It may be severe enough to cause ARDS. Endotoxin also cause hemolysis, cause anemia. Bacteremia is demonstrated in 15 to 20%. Transient renal dysfunction also found in acute pyelonephritic complication. Management. Asymptomatic bacteria treatment with single dose amoxicillin 3 gram, ampicillin 2 gram, nitrofurantoin 200 milligram, cephalosporin 2 gram, dimethoprim sulfamethoxazole 320 or 1600 milligram. 3 days courses with amoxicillin 500 milligram 3 times daily, ampicillin 250 milligram 4 times daily, cephalosporin 250 milligram 4 times daily, ciprofloxacin 250 milligram twice daily, levofloxacin 250 to 500 milligram daily, nitrofurantoin 50 to 100 milligram 4 times daily or 100 milligram twice daily. Dimethoprim sulfamethoxazole 1600 160 or 160 800 milligram 2 times daily. Others. Nitrofurantoin is used to according to clinical symptoms. Nitrofurantoin 100 milligram 4 times daily up to 10 days. Nitrofurantoin 100 milligram twice daily for 5 to 7 days. Or nitrofurantoin 100 milligram at bedtime for 10 days. If treatment failure occurs, nitrofurantoin give 100 milligram 4 times daily for 21 days. Acute cystitis management. Increasing oral fluid intake, nitrofurantoin 100 milligram BD for 7 days. Urine alkalizing agent used. Cranberry juice also acts as a urine alkalizer and it used to treat urinary infection and inhibit the symptoms. Acute pyelonephritic management. Hospitalize the patient, obtain urine and blood culture, evaluate hemogram, serum creatinine and electrolytes, monitor the vital signs frequently, including urinary output, consider indwelling catheter, establish urine output more than 50 ml per hour with the intravenous crystallized solution. Administer the intravenous antimicrobial therapy, obtain chest radiograph if there is any dyspnea and tachypnea, repeat hematology and chemistry studies in 48 hours, change to oral antimicrobials when afebrile. Discharge when afebrile more than 24 hours. Considers oral antimicrobial therapy for 7 to 10 days. Repeat urine culture after 1 to 2 weeks after discharge. Newer antibiotics. Phosphomycin is a new antibiotic that taken as a single dose. It is a broad spectrum antibiotic produced by certain Streptomyces species and has a bactericidal action. Administered as a single dose of 3 grams assay. It is a category B drug. What if acute pyelonephritic does not respond to treatment? Persistent acute pyelonephritic infection. Generally, intravenous hydration and antimicrobial therapy are followed by stepwise deference of approximately 1 degree Fahrenheit per day. With persistent spiking fever and lack of clinical improvement by 48 to 72 hours, urinary tract obstruction or another complication, it is considered to persistent infection. Cause of persistent infection is a urinary tract obstruction, abnormal urethral and pyelocalyceus dilation, intrarenal and perinephric abscess, nephrolithiasis. Management of persistent infection. USG KOB or one shot intravenous pyelogram or MRI may be used to detect the cause of persistent infection. Obstruction relief is important, and one method is cystoscopic placement of double-day urethral stent, percutaneous nephrostomy, and surgical removal of stone. Prevention of recurrence. Prevention of recurrence is behavioral modification and avoidance of risk factor. Non-anatomical measures like cranberry juice, probiotics, and hormone replacement in post-menopausal women. Antimicrobial prophylaxis. Prophylaxis with cranberry juice. Drinking cranberry juice might be the most well-known means of prevention of recurrent UTI. It has been shown to inhibit the adherence of P. purificated E. coli to urothelium and to decrease the virulence in bacterial cystitis. Early randomized controlled trials shows that cranberry juice decreases the number of symptomatic relapses over 12-month period in women with recurrent UTI. Prophylaxis with probiotics. Since the urogenital flora of healthy premenopausal women is dominated by lactobacilli, it has been suggested that restoration of unhealthy urogenital flora from uropathogens from lactobacilli may protect against UTI. Promising result has been the intravaginal lactobacillus crepitus daily for 5 days and then once weekly for 10 weeks. No efficacy seen with oral lactobacillus. Hormone replacement prophylaxis. Estrogen for preventing recurrent urinary tract infection in post-menopausal women. Coherence database 2008 concluded that Intravaginal estrogen therapy in the form of vaginal creams, ring pessary significantly reduce the risk of recurrent UTI in post-menopausal women. Oral estrogens has not effective to prevent recurrence. Vaginal irritation is the main adverse effect and might occur in up to 20% of women. Immunoactive agent prophylaxis. One of the possible pathogen in recurrent UTI is adaptive immune response dysfunction, especially in defect in pathogen recognition. Thus, using a vaccine to strengthen active acquired immunity against uropathogen might be a reasonable prevention of UTI recurrence. Vaginal vaccines significantly reduce the risk of recurrent of UTI. It significantly increased the vaginal and urinary IgG and IgA. A recent meta-analysis published in 2013 enrolled 4 clinical trials of oral vaccine OM89 and shows that it significantly decreased the rate of UTI recurrence. European Association of Urology Guideline 2015 recommend the use of OM89 for immunoprophylaxis in female with recurrent uncomplicated UTI. Antimicrobial prophylaxis. It should be used after non-anatomical agent have failed. Antimicrobial prophylaxis for preventing UTI recurrence can be given continuously for long period of time, 3 to 6 months or a single post-coital dose. A coherence review found that the post-coital prophylaxis was just as effective as low-dose continuous antibiotic prophylaxis in the prevention of recurrent UTI. Continuous prophylaxis for 6 to 12 months significantly reduced the rate of UTI during the prophylaxis period, with no difference between the two treatment groups after cessation of prophylaxis. Post-coital prophylaxis involves the taking a dose of antibiotics within 2 hours of intercourse. It requires a smaller amount of antibiotics than continuous prophylaxis and is associated with a fewer side effect. Antimicrobial prophylaxis doses. In continuous prophylaxis, the daily doses cephalexin 125 to 250 milligram, ciprofloxacin 125 milligram, nitrofurantoin 50 to 100 milligram, dimethoprim sulfamethoxazole 40 and 200 milligram, norfloxacin 200 milligram. And post-coital prophylaxis, one-time doses is cephalexin 250 milligram, ciprofloxacin 125 milligram, nitrofurantoin 50 to 100 in between 50 to 100 milligram, dimethoprim sulfamethoxazole 40/200 or 80/400 milligram, norfloxacin 200 milligram. Conclusion: recurrent UTI might be one of the most common problem in urology clinic. Treating UTI might not be difficult, but preventing UTI recurrence sometimes may be difficult, very troublesome for both patient and doctors. Recent research has revealed many novel concepts in recurrent UTI, including the pathogenesis, risk factor, and biomarkers and prevention. Nowadays, recurrent UTI may be considered as distinct disease and patient with recurrent UTI should be managed aggravatively. Thank you.
Thank you, Sarvesh. Did you find any mistakes in the presentation? Anybody? Multiple. No, spelling mistakes is we accept that they will never correct it. But anything else? So first of all, when he said about the risk factor more than 15 years, that is not true. There's a less than 15 years if there is an infection, that becomes a risk factor for recurrent UTI. Secondly, he said about alkalizer. So alkalizer are not always good while treating urinary tract infection. You have to be very particular. There are particular organisms which grow in alkaline media. All right. And the third thing he said about the meta-analysis 2013, which is a recent meta-analysis. Do you think 2013 is recent?
Even the all the slides are
All right. So be careful about everything, right? To 2013, you think is a recent meta-analysis?
yeah.
You don't have to copy paste. You have to also see what you are presenting, right? So, Nimeshji, do we have anybody from the experts
No,
joining
no,
us?
sir. No,
Dr.
sir. No.
Dalela may be joining, so please let me know when Dr. Dalela joins, right?
Okay, sir.
Okay, thank you. So, a brief summary about the whole recurrent urinary tract infection. The prevalence is quite high, 20 to 30% in women and about 2 to 3% in males, all right? And while dealing with, you must know the definition of recurrent UTI. It is two or more than two pyelonephritis per year, or 3 or more than 3 cases of simple cystitis per year. That qualifies it as a recurrent urinary tract infection. So recurrent could be either a recurrence of the same organism, or it could be a relapse, right? So relapse is when the same organism grows within 2 weeks of completion of the treatment. That is a relapse. Recurrence could be due to the same organism or could be a different organism, but after 2 weeks of completion of treatment, right? So remember these important points. Secondly, you should also remember the risk factors which are associated with recurrent UTI. As I said, less than 15 if you have a first UTI. Then there are many others. There's sexual intercourse, multiple partners, hygiene, and postmenopausal women. And all these are important risk factors that, besides that, you have a genetic factor. Patients who have a family history in mother's urinary tract infection are more prone to develop UTI. It has been seen that there are various genes which are also associated with recurrent UTI. There is a VEGF gene, there is an ACE inhibitor gene, there is an IL-18 gene. So there are a lot of genes which have been studied, which have shown that they are associated with recurrent urinary tract infection. So again, try to differentiate between a simple recurrent UTI with a complicated urinary tract infection. Complicated urinary tract infection is different, where there is either associated sepsis or UTI occurring with children or infants, UTI occurring during pregnancy, and immunocompromised diabetic patients, and patients with genitourinary tract obstruction abnormalities, patients with obstruction of more post-void residual, which has a chance of. So all these can lead to complicated urinary tract infection. So while taking history of these patients, important to take all these notes about the risk factors and the other associated medical illnesses which can be cause for recurrent urinary tract infection. While talking about pathogenesis, remember, 2 things are very important. One is the virulence of the organism, and the other, the host defense mechanism, which is the basis of patients who have more chance of developing urinary tract infection. There are various E. coli strains which have more chance of making urinary tract infection, recurrent urinary tract infection, right? Then, as I said about the intracellular bacilli community, there are some of these bacteria will form intracellular community, and that is the reason why the antibiotics would not work, and there is more chance of recurrence of these organisms because they remain in the intracellular as a living bacilli, right? So again, then the host factors are very important. The pH of the vagina, the hygienic factors, the immunity of the person. So all these are important to develop recurrent urinary tract infection. Management, as I said, is important. So you have to treat the acute infection, and then you have to prevent the recurrence. So acute treatment is according to the culture report. Whenever you do, when we call a symptomatic bacteria, significant bacteriuria, the previous definition was 10 to the power 5, but now it is said as 5 into 10 to the power 4 organisms.
Sir, sorry, Dr. Dalila has joined.
Significant bacteriuria. Yes.
Dr. Dalila has joined.
Dr. Davar. Yes, Dr. Dalila, welcome. Please unmute yourself.
Hello, good morning.
Yeah.
Good morning, good morning. Please go on. I'm listening to you.
Good morning. Good morning. Good morning.
Thank you for having me here. Thank you.
Yeah, I was just trying to summarize. Okay, just stop. So I will just complete it. Then I would just ask you to give your expert comment. Right?
Yeah, you go ahead.
So,
Yes.
So that where I was. So when I was talking about the management, so acute UTI has to be treated, and then you have to prevent the recurrence. So prevention, again, we know that the behavioral management is there. taking care of the hygiene, taking care of, and when we talked about the prophylaxis, I remember when I was with Dr. Dalela, Dr. Dalela and myself was the moderator in a Vaticute um, webinar on recurrent urinary tract infection when he presented Dr. Dalela a full presentation on recurrent UTI, and I moderated it. We were talking many things about how to prevent recurrent UTI. And one of the things that I, during that time, researched was for prevention, the hygiene and everything is important. And there is a role of undergarments also. So that nobody has probably very pointed out. But again, it's not just the undergarments which are usually contaminated with fecal bacteria, could be the cause for colonization of the perineum and the urethra and the vagina, which is responsible for recurrent urinary tract infection. But even those who wear very clean undergarments, they have been found to have fecal bacteria if properly looked into. So again, the undergarments, the tight undergarments and the clothing also would matter because they create a moist and warm environment, which is very conducive for bacterial growth and may be the cause of recurrent urinary tract infection. And now we have for prevention a lot of, besides the antimicrobial prophylaxis, as we discussed, we now have Eurovaccine. We have an oral vaccine available in India also by the name of Uticin, which consists of lysates of various E. coli strains. And that can help to prevent recurrent UTI. Besides that, he discussed about the D-Menos and cranberry and the probiotics. Again, all these are responsible. Another important pathogenesis is the urinary microbiome dysbiosis. As I said, dysbiotic urinary microbiome is again one of the cause for recurrent urinary tract infection, as we discussed about ICBPS also. So dysbiotic, here comes the role of various probiotics and prebiotics, which if can manage this urinary microbiome, can help to prevent recurrent urinary tract infection. So this was in a nutshell a brief summary. Now I would invite Dr. Dalela for his comments. Please, Dr. Dalela. Yes.
Very good morning, everybody. And thank you, Dr. Shivam, for asking me to be here. Am I audible?
Just a minute, Dr. Dalela. We are just trying to get your voice.
Hello. Am I audible to you? Hello.
Hello. Hello. Yes, please speak.
Yeah, am I audible to you now? No.
No, you are not audible. Just hold on.
Yes.
Yes, go ahead, please.
Yeah. Am I audible now? Hello.
Yes, sir. Audible.
Am I audible?
Yes,
Oh.
sir.
Okay, good. So thank you, Dr. Shivam, for giving me this opportunity. Although it's a short notice, I was not prepared to be speaking on it. But you have been very rightly summarizing the reasons of recurrence of infection. But if you ask me the best way to remember preventive strategies for recurrent urinary infection in females, I would say to remember in certain steps. The first step is somehow prevent the enhanced colonization of the genitalia. After all, the infection comes from female genitalia. It grows from outside to inside. So you have to evolve a number of strategies so that you prevent contamination and colonization of female genitalia. And you have touched some upon the undergarments. I would here like to emphasize on constipation in particularly in young girls and elderly ladies. If they are chronically constipated, the the number of bacilli per gram of fecal matter enhances. This is because in constipation, colonic transit time is prolonged. The fecal matter stays for long duration in the colon. So bacteria get time to multiply. So for a particular volume of fecal matter, the concentration, the number, the population of bacilli is far more. And when such fecal matter contaminates perianal area, genital area, it is loaded with volumes of E. coli and causes infection. Constipation can also give rise to some degree of detrusor dysfunction, voiding dysfunction, which will probably contribute to the recurrent urinary infection. So you touched upon all those points which can cut down the colonization of the entry point. That's one. Second is, there are reasons for enhanced entry into the urinary tract in a female. Not every female will have enhanced entry. The enhanced entry happens, there are reasons, sexual trauma, using different kind of sexual practices, that is known to everybody. But what I have noted over the years, that certain females have loss of urethral seal. And when you examine these ladies, then only you will know what is urethral seal. In urethral meatus in female, it remains closed like a, hands, you folded hands, you do Namaskar Mudra. The lips of the meatus are closed. But in some females, there is some degree of posterior urethral prolapse. And because of the posterior urethral prolapse, only few millimeters of mucosa will prolapse out of the urethral orifice, which will result in failure of occlusion of urethral meatus. And this is what is called urethral seal loss. And when these ladies get involved in sexual activity, or they have such unclean garments that you mentioned, the bacteria get opportunity to enter the urinary tract. And this is common in perimenopausal ladies. This is because of hormonal withdrawal. So urethral seal can be restored back with the application of estrogen therapy. So this is second. So first is colonization of the bacteria on the genitalia. Second is enhanced entry in the urethra. Another example of enhanced entry is those who catheterize themselves, or those who are an indwelling catheter, right? Then third is the bacteria entered the urinary bladder, right? Normal defense will eliminate the bacteria. In any female, the bacteria enters, the bladder will void it out and empty it out. So there is a mechanical defense in the urinary system in the female. But those ladies who tend to hold their urine for longer time, if they hold urine for longer time, and if bacteria has entered the urinary tract, bacteria gets that time to multiply from 4 to 8, 8 to 16, 16 to 33, 32, and they reach the critical mass and then cause invasive urinary infection. So very important reason is toilet habits, the voiding habits of ladies. In India, it's very common. Ladies go to their job, they void only in their home, and they come back after a whole day, not voiding even once, and void in the houses because of lack of toilet facilities. And you know that. So then this is the third step. Poor defenses. Bacteria not being eliminated from the urinary bladder. And I also want to highlight to here from my postgraduates that in normal urothelium, there are certain antimicrobial peptides. And these like cathelicidine, and there's one more antimicrobial peptide which is secreted by the urothelium. And whenever the bacteria enter the urinary tract, the antimicrobial peptide will grab the bacteria from all sides, right? And then this forms a kind of a ball, and this ball is expelled in the urine. This is a normal defense mechanism. It is very active in all ladies, in hormonally active ladies. But as perimenopausal area sets in, and also when vitamin D deficiency sets in, and this has been studied in whole detail, that in perimenopausal ladies, if there's a chronic deficiency of vitamin D, there is suppression of secretion of antimicrobial peptides, and they become more prone for urinary tract infection. So this is the third. So prevent colonization, prevent entry in urethra, enhance natural elimination of bacteria, enhance defenses of urothelium, which can knock out the bacteria, right? Anybody who has post-void urinary volume will not be able to eliminate the bacteria. Anybody who has obstructed bladder outlet will not be able to enhance the bacteria. So then there are so many other reasons which you know as a urological resident and also the consultant. In any situation, when urinary bladder is not completely emptied, you will have infections. So these are the host factors. Dr. Shiva mentioned at length bacterial factors, the pathogenic factors, the factors with the bacteria. I'm mentioning to you factors with the host, the individual, the lady, right? So if you take care of these 3-4 steps, probably the recurrence of urinary infection not occur. And also you should remember, for any infection to fight, you need immunity in the body. And for good immunity in the body, there are golden rules, right? Exercise, diet, nutrition, vitamins, and so on and so forth. So once you have a good defense system in the body, because of so many associate factors, naturally incidence of having recurrent infection goes down. So that's what I have to make point on. If something will come to my mind, I'll add on in between.
Thank you, Dr. Dalela, for making those very, very important practical points to prevent recurrent urinary tract infection. You talked about the increasing the immunity. I know you were doing yoga now, and you just took time from you to come to our class. So thank you very much. And second thing that you said about, yes, there are certain proteins, antimicrobial, and probably what you were probably missing was the E-cadherin. E-cadherin is primarily many of these patients who have recurrent urinary tract infection. And the third important, very important point, particularly related to Indian women, is their voiding habits. They usually would prolong, and because we do not find so many toilets, and so many would would not void and would prolong the voiding. That is again a very important cause. Then you said about that coaptation. Yes, very important point that helps in the entry of microorganisms, because all these enter through the perineal, urethral, and the vaginal colonization. And a very important point that I had missed was the constipation. Yes, definitely, there is no doubt constipation, because of the colonic increased transit time, increased bacteria, plus the avoiding dysfunction itself, which is caused by constipation, again, is a very important point in many of these women. Now, most of us are usually suffering from some kind of bowel problem. So again, this is a very important point which should be kept in mind while treating these patients. So I think very wonderfully summarized. Yes, Dr.
One more point I mentioned, many ladies in Indian population have vaginitis. Many ladies in our population have recurrent vaginitis. And this is because of the cervicitis that they have. So they keep pouring vaginal discharge. The vagina is wet all the time, and it has polymicrobial flora, which can, whenever they involve in sexual activity, immediately after that, they get postcoital urinary infection. So if the lady is giving you a history of postcoital recurrent urinary infection, or you should be careful about asking, unless you ask these ladies the leading question of chronic vaginal discharge or intermittent vaginal discharge, foul smelling vaginal discharge, you will not catch this point. And in the patients of poor,
thank you.
In the patients of, one more point I'll add here quickly before I leave. In ladies of poor urethral seal mechanism, I have given them an antibiotic cream to apply on the urethral meatus. And whenever the ladies have this, I tell them to apply this after the bath, and it will stay there for a few hours or before they go to bed. Just some cream on the urethral meatus. And this has given dividends in many patients. The recurrence level goes down. If it occurs, the virulence of attack is not so much.
Yes, very, very important point. Yes, I think that you have learned from your own experience some very, very important points. And we appreciate that, yes, application of antimicrobial at the entry point may help to prevent recurrent urinary tract infection. And you talked about vaginal secretions and all that. Yes, now a lot of work is being done on vaginal dysbiosis and bladder dysbiosis. So anything which results in dysbiotic vagina or the urinary bladder can cause recurrent urinary tract infection. Yes, very, very important points brought out. Thank you, Dr. Dalela, for joining
you.
us. We
Yeah.
usually end up with few MCQs for the benefit of our residents. So we will start with the MCQs. Please. So the first MCQ is bacteriuria without pyuria is indicative of infection, colonization, tuberculosis, contamination, stones.
Colonization.
Colonization. Okay, let's see. Colonization is generally indicative of bacterial colonization without infection of the urinary tract infection. It's very important to understand pyuria could be due to causes other than infection also. And also remember the dipstick test, which can tell you about the nitrite test and the leukoesterase, which can help you to detect urinary tract infection before you do the culture. And again, culture, again, very important from where you are taking. If it's a midstream, the significant bacteriuria would be about 5 into 10 to the power 4. If you are taking a catheterized sample, it would be 10 to the power 3. And if you are taking a suprapubic aspiration, any organism present in the urine would qualify it for UTI. So next question, approximately 10% of symptomatic lower UTIs in young sexually active female patients are caused by E. coli, staph, 10%. 10%. Staph, Saprophyticus, Pseudomonas proteus, staph epidermidis. I think this is staph. It has to be Saprophyticus. So is recognized as causing frequent symptomatic UTIs in young sexually active females, where it rarely causes infection in males and elderly individuals. So the commonest organism again remains the E. coli 80% of the time. The finding that first suggested a biological difference in women susceptible to UTIs is increased adherence of bacteria to vaginal cells, decreased estrogen concentration in vaginal cells, elevated vaginal pH, non-secretor status, post-menopausal status.
Elevated vaginal.
So the first finding that suggested the biological difference, how it, so it should be, I think, adherence, is it?
Yes.
Yes, increased adherence of the bacteria to vaginal cells, because there is a molecule called adhesin molecules, which helps in more adherence. Plus, there are bacteria which has P. fimbria, which are responsible for increased adhesion to the vaginal cells and the urothelium, which is responsible for urinary tract infection. Number 4, severity and morbidity of bacteriuria is most morbid in patients with spinal cord injury, pregnancy, reflux, diabetes, and HIV infection.
And
is it spinal cord? Patients with neurogenic definitely have increased morbidity, but spinal cord, yes. So of all patients with bacteriuria, no group compares the severity and morbidity in patients who have spinal. So patients with neurogenic bladder following spinal lesions have maximum chance of this morbidity. And so remember that. The host factor least likely to be associated with an increased risk of infection is advanced age, a history of previous infection in the site organ of interest, residence in a chronic care facility, indwelling orthopedic pins, and coexistent infection.
indwelling
Orthopedic, I think so. Yes. So a bacterial seeding of implanted orthopedic hardware is rare but morbid event. A joint commission of AUA, and infectious diseases that reconvened in 2000 released an advisory on prophylaxis of urologic patients with total joint replacement. In general, antimicrobial prophylaxis for urological patients with total joint replacements, pins, plates, screws is not indicated. So the most common cause of unresolved bacteriuria during antimicrobial therapy is development of bacterial resistance, rapid reinfections, azotemia, staghorn calculi, initial bacterial resistance. So I think this is a bacterial resistance. Yes, initial bacterial resistance. Most commonly, the bacteria are resistant to antibiotics. So very important, the role of antibiotic policy, antibiotic stewardship in treating these patients, because we have to treat the acute UTI. We can't wait for the culture report to come. So important, which antibiotics will be more sensitive is very important to understand. The most effective measure for reducing catheter-associated UTI is closed drainage, antimicrobial prophylaxis, catheter irrigation, intermittent catheterization, and daily meatal care.
Antimicrobial prophylaxis.
Is it a closed drainage or closed drainage? Sorry. Yes, because not every patient requires an antimicrobial prophylaxis. So careful aseptic insertion of the catheter and maintenance of a closed dependent drainage system are essential to minimize the development of bacteriuria. Here, I would like to say, I remember Dr. Dalela and his YouTube where he teaches how to put catheter in a very aseptic manner. It's very important to understand this may be a cause for UTI. So very important to learn how to introduce catheter, how to keep the catheter with the bag in a very aseptic manner. In spinal cord injured patients, the bladder drainage technique with the lowest complication rate is CIC, suprapubic drainage, indwelling catheter, condom catheter, suprapubic pressure. So CIC, I think CIC should be the answer. Yes, although never rigorously compared with indwelling catheters, CIC has been shown to decrease lower urinary tract complications by maintaining low intravesical pressure and reducing the incidence of stones. Thank you. I thank once again Dr. Dalela. If you would like to have last comments, and then we will wrap up the session. Please unmute.
Yeah.
Yes.
See, it is extremely vital to listen to the patient when you are treating a patient of recurrent urinary infection. If you don't take a good, proper history, and if you don't allow the lady to speak, what is her impressions about the recurrence of urinary infection? And most important point by the patient will be told in the end statement of her history. Because it is by the time she gets open with you in conversation and she is trying to reveal to you her most hidden secrets, why she's getting recurrent urinary infection. So please listen to the lady carefully, let her speak out. And that is the clinch of diagnosis of recurrent urinary infection. That's what I've learned over the years. And that's a very nice presentation, Dr. Shivam, you mentioned here.
Thank you. Thank you, Dr. Dalela, for making that very wise remark. Definitely, it holds good for urinary tract infection. It holds good for every problem. So very important to talk to the patient, let the patient talk to you and develop a rapport and let her come out with her problems before you start treating. So very important and very wise remark made. Yes, go ahead, please. Yes.
One more point. When you are
Yes.
treating acute urinary infection, you have to have a very high concentration of the antibiotic in the urine. At that time, don't ask the patient to drink a lot of water unless it is exudative infection in the urinary tract, unless there is a frank pyuria in the urinary tract, unless it is odorous, foul-smelling urine. If it is a clear urine and patient has acute urinary infection, if you ask the patient to drink a lot of water, 4 liter, 5 liter, the concentration of antibiotic in urine will go down and the infection will not be eradicated soon. So remember, treatment of acute infection, don't enhance liquid intake. When you are treating recurrent urinary infection again, it is said that you ask the patient to drink a lot of water. It will flush out the urinary tract. Fine. But look at the caveat. Caveat is drink more water, empty a urinary tract more often. So anybody who has obstructed bladder outlet, anybody who has residual urinary in the bladder, to this patient, if you enhance liquid intake, enhance water intake without addressing these problems of bladder outflow obstruction, without addressing the residual urinary volume in the bladder, you will not gain the advantage. So you have to read between the lines before you follow these things and start instructing your patient about these things.
Thank you. Thank you, Dr. Dalela. Very important point made again, because the patients are usually in the habit and probably think that taking a lot of fluids will wash out the bacteria and help her to manage the urinary tract infection. So very particular thing that you have to maintain is that take adequate amount of fluids, not very less, not too much. Adequate amount of fluids with antimicrobial would help these patients. And a very important point made. Thank you. Thank you, Dr. Dalila. Thanks all the faculty, residents, and those today who might have joined us. Thank you very much and have a good day.
Bye bye.
Thank
Thank
you.
you. Thank you.